Hi everyone. Thanks so much for inviting me to speak today. I apologize that I can't be there in person. I'm working clinically the weekend that this is going to be, so I might see some of you guys in the emergency department tonight. But just wanted to thank you guys for having me. So some of you probably know who I am. I've met probably most of you by now. I'm one of the ER docs at UPMC Lidditz. I'm here today basically just to give a lecture on altered mental status. It's a lecture I've given before. It's kind of a tough topic, so bear with me as I kind of jump around a little bit. But I think it's a worthwhile topic to kind of go over. It's something that we all experience pretty frequently, and in and of itself is pretty tough to kind of figure out at times, even in the ER and even past the ER during inpatient hospital stays. It can take quite a while to truly figure out causes for altered mental status. But since it's such an important thing and something we see so often, I put this together a year or two ago, and I think that it's pretty pertinent to what we do every day. So I have no financial disclosures. And before I start, just to introduce myself, like I said, I think I've met most of y'all. My name's Kyle Birch. I'm one of the ER docs at UPMC Lidditz. I've been an ER doctor out of residency now 2 years. Last year I was one of the EMS fellow physicians and EMS physicians for Lifeline EMS and Lifeline Critical Care up at Penn State. Before that I did my residency training at Christiana Care in Delaware, and then before that went to med school in Penn State. So I've been around the area here, and I'm happy to be back working in the ER at Lidditz now. All right, so just going to start out here with a quick outline of what I'm going to go through today, that way to hopefully keep things at least a little organized. But we'll start out defining altered mental status, which I think will help us kind of figure out a little better as to why it's so difficult to really pinpoint causes. What I would recommend as an initial approach to patients with altered mental status, what parts of the assessment are really important and helpful. And then next, going through different etiologies. And I try to dig into some of them from mostly the basic level and then kind of build my way up and add some kind of maybe a little more interesting kind of science tidbits for some of them just to keep it a little more interesting for everybody at all kind of different levels. And then if we do have some time, an altered mental status case, and then we'll go from there. So what is altered mental status? I think the kind of first thing to start with is altered mental status is not a disease. It's a symptom, right, of a disease or a pathology. So when you get the dispatch for altered mental status, you really don't know what it is that's causing this. You just know that it's either someone that's confused, it could be someone that's completely unresponsive, to someone who maybe is just slightly not their normal self. I think we've all been to nursing homes where they say, "Oh, they're just not themselves today." Sometimes it can just be memory loss. Somebody's not remembering things. It could be subtle, where somebody who typically can do their kind of financial work, all of a sudden you notice that they can't pay their bills, and that's less acute, but just some of the things that maybe family members might pick up on and say something to you about. Sometimes it's change in judgment. People making decisions they wouldn't normally make, riskier decisions, and that there might be an underlying kind of reason for that, whether it's drugs or a metabolic reason, and then just disruption of perception. So maybe patients are seeing things there that they don't truly see. They're perceiving the situation different than reality. A lot of our psych patients kind of fall into this realm. So I think what makes altered mental status particularly difficult is that there are so many possible etiologies for why someone is altered. This is not always easy to figure out. It takes sometimes quite a bit of time, but the hard part is figuring out what's leading to this is kind of what allows us to treat the patient appropriately and try to either reverse it or support the patient in a way that they need help, just kind of be able to get over this period of confusion or to keep them safe. Other things that make it difficult, the patient may not be able to provide you any information. Maybe they're, unresponsive, or they're not clear in their speech. They might be saying things completely bizarre. They might just be staring at you. I think, really we get the majority of our patient information often from the patient talking with them. And often with altered mental status, they really can't tell you much. Like I said, particularly severely altered people, they might not be able to add anything meaningful at all for you to really run off of. So that makes it a lot harder than just the typical patient encounter. And then, another issue is that today's problem might be different from yesterday's problem. Like I was kind of alluding to earlier, patients, there's a lot of patients that we might see pretty frequently with altered mental status, your diabetics, your alcoholics, your drug addicts. But just because they have one issue today, it doesn't mean it's the same issue. You think of your dementia patients, of course they're kind of always confused. You might encounter them and notice that they're not their normal self, but the next day you might come out for a call and they're even more altered. And is it because of sepsis or UTI? Did they fall and hit their head? So sometimes not anchoring is kind of a big thing. And that kind of leads into the last kind of thing about what makes it so difficult, is that you can't really just assume it's one thing. And I think that we would love all of our altered mental status patients to be caused by one problem that we know how to address, that we can fix. But a lot of times it's multifaceted, and we really can't assume when you approach a patient who is altered that there is one true cause for this. So, gathering all the information you can is really helpful in trying to figure out if there's kind of a multifaceted reason for why this patient is altered. So the first step with these patients is just coming up with our initial approach to them. I think this is something, of course, we do with every patient we see. We try to kind of develop a systematic way of trying to figure out what's going on. And so this is kind of the things that I would do, and I think it's probably the things that you guys probably already are doing. But I figure it's always good to highlight and just re-review kind of a systematic approach to interviewing patients and gathering information, particularly in patients where it might not be as clear what's going on, particularly these patients with altered mental status. So the first part for me is just kind of looking at where the patient was found. So I think we all know that situational awareness is huge. Patients can really be found in anywhere, right? I mean, you get called out to people's residences, but you also get called to places of work, the middle of a field, the road. I think things that are really helpful is where exactly was the patient found? Were they out in the environment, or were they in a workplace where it was very hot or very cold? Environmental factors often can play into altered mental status. Is it a farmer at in a barn? And that adds a lot of kind of questions as to what's in that barn, or what were they handling? Were they exposed to pesticides? Were they exposed to some other harmful gas potentially? Were they just up in the silo? Um, is this patient coming from an industrial site? And what type of industrial site? What type of solvents, chemicals, or exposures does that industrial site have? Because that information might be the biggest part, or the biggest key to figuring out why this patient's confused or altered. Other places, like I think I've had patients come in from college laboratories. It's amazing how many dangerous compounds and chemicals can be found in just a simple college lab. And we all know that there's plenty of universities around, even high schools. High school science rooms. There's still access to compounds that can cause confusion. I mean, even simple cleaning solutions, as we all know, can give off gases that can lead to confusion. So, just looking around, of course, when you first get there, and trying to put into place, okay, where am I at, and what are the possible kind of environmental or external causes for altered mental status is kind of the first thing you do. And of course, probably I should always say before all this, making sure that you're safe. But I know that that's kind of what everybody already does. But never a bad time to just remind you to keep an eye out, that if someone's down, make sure that you're not putting yourself into exposure to a dangerous gas. We all have heard stories of providers going in and unfortunately succumbing to the same exposure that their patient was. So being aware of where the patient is, where they're found, is not only helpful to us figuring it out, but also helpful to keeping yourself safe. Are others along with the patient acting abnormal? I think this really comes into play with things like carbon monoxide poisoning, or other environmental exposures. If more than one person are having symptoms, there's a good chance that there's an environmental exposure that everybody came into. Look for or kind of try and investigate the possibility of a fall or trauma. Does it look like there's any possible chance that this person could have been injured? Was there evidence of a struggle? Um, where are there areas right next to the patient or nearby where the patient could have fallen? Obviously, does the patient have signs of trauma on themselves? But just kind of looking at the scenario around them, is there something that could explain trauma to the patient? So next, obviously history is huge. Like we were talking about earlier, sometimes the patient might not be able to provide you any of that history. So gathering that information is probably going to be pretty multifaceted. It might be gathering from quite a large number of different people or resources, whether that's family or friends who are nearby, coworkers, others on scene, whoever called 911. But oftentimes with these patients, you have to kind of get creative in picking up information. So other things, obviously grabbing patient's name and demographics, their ID if you can. I know sometimes these patients are pretty sick and you're trying to focus on them, which obviously is the most important part, is taking care of the patient. But before you leave with them, if there's even a way just to get a little bit of identification, if it's there sitting next to them or something, if you can bring it, it's really helpful because oftentimes we have their medical records, and we're able to kind of get into their medical records once they're in the emergency department and see something possibly in their history that could explain why they're not acting like their normal self or not able to answer questions. Medications that are lying around them, obviously this goes into not only just what the patient takes, what type of medical problems they have, but also potentials for overdoses, looking at what bottles are there, how many pills are in them. If you're able to just bring them with you, that's awesome. That way, I know you guys are already going to be busy enough caring for the patient, trying to get them to the hospital safely. Sitting there and counting how many tabs are there and calculating back to the date might not be something you have time to do before getting that patient treated safely. So even if it's just bringing them with you, we'll obviously take a look at them once they arrive. And I think it's obviously another huge kind of component to figuring out what's going on with patients that are confused at times. A big thing I also find helpful with history, particularly our dementia patients or patients with special needs, nursing home patients, is if there's someone that can kind of tell you what's the patient's baseline. What's the patient like on a good day? We all know that dementia patients or patients with certain special needs often can seem confused, and that can really just be their normal self. So trying to find out what the patient is like on a good day is helpful so that we know what's that patient's kind of baseline. And then, specifics of how are they different from today. Is it that they, just didn't eat? Or is it that they're repeating themselves? Maybe they're verbal and now they're nonverbal today. Maybe their speech sounds off. These kind of pieces of information can help us figure out what exactly could be going on with this person who might not be able to tell us themselves. Gathering a timeline with the history is really important. Was this something kind of gradual over the past couple of days? Could it be something infectious that has been slowly worsening, or was this something sudden? Did the patient have a stroke? Did they just have a seizure and now they're postictal and they were found that way? Was there trauma that led to a sudden change, or acute environmental exposure? The things that cause altered mental status gradually versus suddenly are quite different, and so it can help us really narrow down possible etiologies. Medications, like we kind of already mentioned a little bit, what medications does the patient take? Does this patient typically manage their own medications? Is there somebody else who does it? And do they have a log? Do they know which patients that what medications that patient took already today? And were there any changes to medications recently? It's not uncommon that a lot of patients come to the ER and they'll have kind of a change of behavior or new symptoms. And if I ask them, oh, do you have any recent changes to your medications, a new one, increase or decrease in dose? And often we find that that's happened, and that can be causing the patient's symptoms. So gathering that information from someone around can be pretty helpful. A question that I really like at times, especially when I really am kind of lost with where to go and figuring out what's going on, is if there's the patient themselves, if there's have some insight and can answer, or I mean, even more helpful is family or friends. Ask them kind of what do you think's going on. People, often have an idea, or maybe they're kind of weary to say something, do they know that their family member or friend's been using opiates or, using some other drug or alcohol, or they have their suspicions, but they're not sure. But if you word it like, is there something that you think could be going on, or you're not sure or anything? Like what have you kind of seen, or what would you guess? Oftentimes it kind of opens up just an opportunity for them to maybe bring up those things that maybe they would not be as comfortable saying, or maybe they just kind of have an idea, and instead of kind of chasing your tail looking for a cause for this, the family member or friend might know exactly what's causing it. So trying to get that information from them with just an open-ended question like that can really be pretty helpful. All right, so our initial assessment then kind of continues with our exam, which I think with obviously every exam we really start with the important stuff, the ABCs. And just like with any other patient, you want to hit the critical interventions first, and then kind of going from there. So obviously, this is something I think everybody knows, but start with your airway. Make sure that the patient's protecting their airway. Are they breathing? Going down respirations, then are they effective? Just observing are the respirations fast or slow can obviously kind of give you a bit of information as to what's going on with the patient. And then circulation, of course. So good pulse, rapid heart rate, or is it a bradycardia? Are they hypotensive and they need kind of acute intervention for their blood pressure? So obviously the basics are always the first start. After that, obviously we kind of move on to disability. So you can do a GCS on the patient if you want to. I wouldn't harp over the number too much. I'd rather have the information as to, kind of what makes up the GCS than always a direct number if you can't remember. So if you can just describe the patient, what's going on, what you see, kind of how interactive they are. A lot of times that's just as helpful as the number if you're not recalling all the different components of GCS. So look for focal neurologic deficits. Obviously strokes can cause confusion or altered mental status. So are they flaccid on one side in their upper and lower extremities, facial droop, sensation loss? Look for seizure-like activity, rhythmic movements. Are they unresponsive but they have a gaze deviation? Are they doing that kind of tongue or lip smacking and unresponsive? Do you notice that their head is turned in a particular direction? Or are they just blatantly confused, and could this be a postictal state? Next, it's always important, particularly if the patient's unresponsive or really significantly confused, to expose the patient. And I think sometimes we don't do this as much as we should, particularly in both trauma patients, just critical patients. Exposing them can give us so much information at times. Their clothing, is it covering up a piece of information that would help us figure out what's going on. So if they're critical, I would definitely try to expose them completely. And then of course you can cover back up with a blanket, but getting their clothes off and taking a look for drug patches. Nursing home patients, it's not uncommon to find fentanyl patches. You can find nicotine patches, estrogen, testosterone, clonidine, scopolamine, and sometimes people have multiple patches on, and they're not taking them off, or their caregiver's not taking them off, and now they're overdosed on one of these um, medications with a drug patch. So take a look. If they have 5 or 6 patches on of the same thing, good chance is that they overdosed on this medication. Take a look for dialysis catheters. Obviously, if you see a dialysis catheter or a fistula, this is a dialysis patient, and that really changes kind of way in which we can oftentimes approach these patients looking for common causes of altered mental status in dialysis patients. You can also find PICC lines. Is someone's home on home antibiotics, and could they be septic? Or ports in your patients. Often patients who are on chemotherapy or cancers can have ports in place. Look for signs of trauma. Does the patient have bruising, deformities, obviously penetrating trauma? Is there some sort of sign that was there an injury that occurred that could have caused the patient to be unresponsive or not acting like themselves, confused, nonverbal? Look for insulin pump or insulin injection sites. Is this a diabetic and they just have a low blood sugar or they're in DKA? And then after all this, of course, early on, checking a finger stickos. It's always kind of embarrassing when you have someone that's unresponsive, you're doing all these things, and then, all of a sudden you get around to checking a blood sugar and it's 10. And all you needed to do early on was try and correct that sugar to work on the patient's mental status. So make sure you're getting an early blood sugar, because that's something that we can obviously quickly and easily reverse to help improve the patient's mental status. Here I just wanted to throw in just a quick visual reminder. I think probably everybody's seen a lot of these, but for those who may not have, dialysis catheters can kind of look quite different at times. Some people just have a port up on their, have a catheter up in their chest. Obviously fistulas in the arms, which you should be able to kind of palpate a nice throb or thrill over those. Or peritoneal dialysis. Do they have catheters in their abdomen? There's quite a few different lines and catheters that patients can have. So things to look for, and let the ER know when you get there that you've noticed this, because that obviously can help kind of guide potential causes for altered mental status. Just a side note, something I always find helpful to remind everybody is if you ever have a patient that has like a catheter or Foley or peg tube or something along those lines, and you get called out for a dislodged tube or broken tube or problem, if it's out, just make sure you try to bring it with you to the ER, because it's pretty helpful to us trying to figure out what type of line and catheter it is, the size, if we're going to try and replace it pretty quickly. So little side note, it's just helpful, and I always appreciate when people bring them in, because then it's a lot easier to figure out what the patient needs kind of going down the line. All right, so causes. So this is where we're going to spend quite a bit of time kind of going through what I would say is a bit of a differential for causes of altered mental status. And it is true, the possibilities are endless at times, it feels like. So it's pretty easy to get lost. There are so many different causes, there's so many different routes you could go, particularly with pretty complex patients who have a lot of health issues. There are so many different reasons for why they could be altered. Or if you just find someone and they're completely unresponsive and you have no information, it's easy to get lost trying to think through causes. So there's an acronym that we use in med school, but it's called AEIOU TIPS. It's an acronym that you can use to kind of help remember different altered mental status causes. Might give you just some little bit of framework to go through in your mind if you're feeling like you're stuck trying to figure out what intervention you might want to do or what could be going on with the patient. A little bit of just a systematic approach. So what I'm going to do is kind of just go through each letter with some things that are associated with. I'll try to dive in a little deeper with each of them just to kind of give you a little extra information. So the first A is alcohol. So obviously probably the easiest with alcohol would be just acute alcohol intoxication. Is this your homeless patient that you frequently find intoxicated? Is this a college student? Is this just somebody that was out drinking at dinner and is slurring their speech or confused? Alcohol in and of itself is an intoxicant and can cause these symptoms. But there's quite a bit of other altered mental status generating causes from alcohol. So obviously acute alcohol withdrawal. So patients that are in alcohol withdrawal might be agitated, they might be hallucinating or having visual hallucinations, they might be having seizures. Alcohol withdrawal, as we know, is not only dangerous but deadly. So common cause of confusion. Alcoholics over time can develop Wernicke's encephalopathy. These patients deplete their vitamin B stores, particularly thiamine, and this leads to actually really permanent brain changes over time that can lead to kind of a confused state in these patients. And then other things to think about are toxic alcohols. So methanol, ethylene glycol, isopropyl. So methanol commonly found in windshield wiper fluid, can also be found in paint removers or thinners, or sometimes patients homebrew. Other things we see ethylene glycol, so antifreeze. It's something that we sometimes see in intentional overdoses and suicide attempts. And an isopropyl, rubbing alcohol is pretty easily found. Some patients will attempt to drink this, particularly alcoholics at times, in a desperate attempt to ingest an alcohol. So just something to look out for if you see that when you're on scene with the patient. So just some maybe interesting information. So ethylene glycol, like I said, that's more on the antifreeze end. It's typically odorless but sweet tasting. Kind of what's interesting about it is it's metabolized in the body to a couple different metabolites, and these are toxic, basically, and lead to a metabolic acidosis. Interestingly enough, what you'll see with these patients is they start to precipitate crystals in their urine, and their urine will actually fluoresce under like a black light or UV light. So if you see that picture up in their corner there, it's showing basically that that patient's urine is fluorescing, which I think I've seen twice now. Both patients were pretty sick, and we had them in the intensive care unit, and after some kind of investigation and looking at their kind of metabolic conditions, we were able to kind of ascertain that it was ethylene glycol poisoning, and then see if the urine glowed. So just like a interesting little fact there. So next is E. So think about epilepsy, electrolytes, encephalopathy. So epilepsy, obviously we've all taken care of seizure patients. Did they just have a seizure, or are they post-ictal? Confused. If you get there and someone's confused, combative, and they're like, oh, they have seizures, this is what always happens, this is probably not uncommon for them. Other things to look for, an E would be electrolyte abnormalities, so hypernatremia, hyperkalemia, hypercalcemia. There's a lot of causes for all of these. People who've been taking different medications, different diuretics, patients with cancer, or patients with psychiatric disorders can develop a lot of these different metabolic changes to their electrolytes, or just when people are sick. Interestingly enough, we saw, I want to say it was with the Delta variant of COVID coming through, I saw quite a bit of patients with hyponatremia. So a lot of causes for electrolyte changes, but these in and of themselves can cause altered mental status. Encephalopathy. So think of like hepatic encephalopathy. Does the patient have cirrhosis? Do they look jaundiced? Do they have a protuberant abdomen? They build up ammonia, and now they're confused because their ammonia levels are really high. Other things to think about is just post-anoxic encephalopathy. So could the patient have been hypoxic for a period of time, and that's led to kind of a confused state, which sometimes is not reversible, oftentimes is not reversible. So just different causes for encephalopathic changes in our patients. So here I just wanted to kind of step through a couple EKGs because I enjoy EKGs, and it's the perfect time to talk about them with the electrolytes. So I'd mentioned hyperkalemia. So could it be your dialysis patient that's missed dialysis? So if you look here, this one here is demonstrating peak T waves. You can see those T waves are pretty tall and sharp looking. I think I was told if it's a T wave you wouldn't want to sit on, then it's peaked. So if you see diffused peak T waves, be worried about hyperkalemia. And then as hyperkalemia progresses, you then start to see a widened QRS here. So this is a pretty scary looking EKG. I think if you see this, be scared. I'm scared if I see this.
I would definitely be pulling out the calcium here and trying to intervene quickly. And then hypocalcemia. So hypocalcemia causes prolonged QT. So if you look at this EKG here, there's a pretty good QT segment. So things to think about, and if you see them, be aware obviously that these different electrolyte abnormalities can be arrhythmogenic, so just be wary, make sure if you can have the patient on the monitor, and be aware that if their mental status changes even more, could they have gone into an arrhythmia. So next is I, which stands for insulin. So you're diabetics. So obviously diabetics can be altered for quite a variety of reasons. So probably the easiest one to think about is low blood sugar. So that's a quick and easy one to kind of figure out. Do a finger stick blood glucose. It's low, and obviously you want to go ahead and try and treat them for that. If it's low and they are able to take PO, obviously you can use oral glucose and then chase that if you can, ideally to get them to eat something that's a little more substantial, that has a little more complex carbohydrates to it than just glucose or dextrose. But obviously then you have your other agents, glucagon or your IV sugar solutions, depending on what your trucks are carrying. Other things with diabetes, diabetic ketoacidosis. So is this somebody who's either a new diabetic? Could it be someone that just has not been taking their insulin because they haven't had access to it because of, insurance reasons, travel reasons? Is it someone that's just been sick and hasn't taken any of their medications, and now they've developed diabetic ketoacidosis? So these patients, they always kind of traditionally talk about, you might smell ketones on them or they have that sweet smell. Sometimes they do. I can't say they always do. So if they don't, it does not mean that they don't have DKA. It's just something you might notice. And then, like we kind of talked about before, make sure you're being observant with these patients. Look at their medications. If you see they're on metformin, that's something that's helpful because sometimes metformin can cause lactic acidosis. Metabolic acidosis is causing the patient's altered mental status. Other things to look for: an insulin pump. Is their insulin pump malfunctioning? All these different things are helpful in us to figuring out what's causing the patient to be altered from their diabetes. So DKA, just a little dive into that here quickly, is like I said, basically when the body is deficient of insulin, the body has to now use different pathways to provide glucose or break down glucose and sugars to metabolites that the body can use for energy. So often what will happen is the body starts to metabolize triglycerides and amino acids instead of glucose, and does ketogenesis. So now you develop a metabolic acidosis. If you want, you can feel free to pause the lecture here and take a closer look if you need to at the diagram here, or come back to it. But just things to think about with it. So they will have, often they'll be breathing fast, and what happens is they develop this metabolic acidosis as their body starts going through ketogenesis, and they will then breathe fast to try and correct that through respirations by dropping their CO2. But unfortunately, oftentimes you can't keep up with it, and it keeps getting worse, and they can get altered, they can become hypotensive. Other things that are happening is that their electrolytes are shifting, so you might notice their sodium's low, their potassium's high, and then they develop the anion gap acidosis, which is one of those hallmarks that we look for. So diabetic ketoacidosis is scary, particularly pretty severe DKA. These patients are severely dehydrated because they're not processing the glucose that they're eating. They're basically just peeing it out, and basically when you think about any solute, when you're adding it to a solution, more water is going to flow to the more concentrated solution. So as the body's dumping glucose into the urine, it's pulling water and free fluid with it, and the patient's becoming pretty significantly volume depleted. So patient with DKA needs aggressive fluid hydration. All right, next is O. So O is opiates and oxygen. So unfortunately, we all know that opiates are a kind of quite the epidemic of themselves. We've been seeing increasing issues with opiates over the past, oh gosh, many years, and now we see people coming in with overdoses from synthetic opiates that are pretty strong compared to what a lot of these addicts are used to. We can have different batches of opiates that are laced with other drugs or more synthetic opiates that can be pretty difficult to reverse. So opiate overdoses are unfortunately pretty common, and not all of them are from people abusing drugs. Sometimes it's just from somebody who's responsibly prescribed an opiate and they develop you know medical issue that's leading to them to not clear it as well, and they've accidentally built up unsafe amounts, and they've suppressed their respiratory status. Sometimes, like I said earlier, with patches, nursing homes can accidentally forget to pull off one fentanyl patch, or the patient themselves might forget to pull off the old fentanyl patch, and they keep adding them on and don't realize and overdose that way. So obviously, with opiates, you look for small pupils and look for a reduced respiratory rate. So if the patient's breathing fast and not responsive, much less likely that that's an opioid overdose. The caveat, though, to remember is that patients often, unfortunately, are multifaceted. So, the reason for them being altered might be kind of multifaceted, with opiates being one of the reasons. So, opioid use and opioid overdose can cause altered mental status, both as intentional overdoses or recreational overdoses, or in responsible uses by patients who are prescribed. All can lead to dangerous overdose or altered states. Opioid withdrawal is pretty uncomfortable for patients, but less deadly than alcohol withdrawal. But what you'll see often, you might notice that they're sweaty. They'll have goosebumps. They'll be vomiting violently, uncomfortable, tachycardic. So things to look for with them that you'll notice. And you can ask. Sometimes patients will be straight up with you and they'll admit, yeah, they haven't used, or they haven't gotten their methadone and now they're withdrawing. And then the other O is oxygen. So hypoxia. Other things to think about are be also hypercarbia. So is the patient asthmatic and they're having an asthma attack and difficulty breathing, and that's why they're confused? Is it a COVID patient and their pulse ox is 68%? Are they someone that has pneumonia? Do they have a pneumothorax? All these reasons can cause hypoxia, and hypoxia can lead to altered mental status. And then hypercarbia, so high CO2 levels. So hypercarbia, you think of like your asthmatics or your particularly your COPD patients, and when they have an exacerbation, are they retaining and they're not clearing as much of their carbon dioxide, and as it builds up, it leads to acidosis and can lead to confusion, sleepiness, fatigue. So something that you'll notice with these patients is often like it's something when I see a really kind of sleepy, fatigued, short of breath patient that I know has COPD, I usually right off the bat get a venous blood gas, because good chance they're not ventilating well and they developed a respiratory acidosis with hypercarbia. So if you look at this diagram here, it's a little all over, but this is basically just a kind of a simple diagram of how our body acid-base balances. So you kind of have two ends. You have the metabolic side, which is pretty important with the kidneys clearing bicarb, and then you have the respiratory side, so body can clear acid or bases through respiratory state through CO2. So respiratory acidosis, you might see that, like I said earlier, in somebody who is retaining or not breathing as well, like a COPD patient. And so their CO2 level builds and it drives an acidosis to form. One way to fix that is then to make them breathe faster, to try and breathe that off. And at the same time, their body is trying to, from the kidney end, compensate by changing which electrolytes and bicarb are exchanging at the renal level. It's kind of a interesting pathway. It's something I'd recommend looking up and just kind of looking over when you have some time, if it's something you're interested in. Like I said, a lot of this is just kind of a little deeper dive for people who might just be interested in knowing the kind of physiology behind this. But this is what drives a lot of the treatments that we do for patients. And when you understand that, it makes it a lot easier to kind of understand the steps to take in treating someone who is coming in with a particular issue. So um, hypoxia, acidosis can all cause altered states, and doing steps to kind of basically balance that back out if you know the reason for why they're acidotic or having trouble breathing or having hypoxia, you could then kind of correct that. Just a little diagram. I think everybody probably understands this, but opioids, what happens when you use Narcan is the Narcan, the naloxone, it basically blocks the receptor and displaces the opioid off of those receptors. And so this is something that can be done intranasally. You can give it IM, IV. Just know that, of course, when you give it, it's going to quickly reverse the patient's altered state. You can, I'd recommend everybody obviously review the protocol. It's good to know, what your protocol you carry. You'll also notice that other services you interact with might carry Narcan, but it might be in a different form. I believe most of the police services are still carrying the 4 milligram intranasals, but I know there's some auto injectors out there that you might run into. Sometimes the public will have them. So there's kind of a variety of different amounts. So important to kind of know how much the patient's gotten. And after they get it, you got to watch their respiratory status. One, because the respiratory state can depress again, but two, they can develop pulmonary edema from post-Narcan state. Just some pitfalls with opioid overdoses. Remember that these patients might not just be an opioid overdose. So it's not uncommon in a lot of areas for people to be mixing drugs. And so just be aware that, just because you try to reverse the opioid doesn't mean that they're not under the influence of something else. And make sure that when, you might suspect that it's an opioid overdose, just make sure you're not anchoring on that too much. If you've given 4 milligrams of Narcan and there's zero response, I know by the protocol you can give an additional dose, but just kind of maybe start thinking about other causes if that's not causing any change in status. Are there very, very strong opiates out there that require very significant amounts of Narcan to reverse? Yes, but they're not nearly as common. So I think the danger is often getting too far down the rabbit hole of trying to reverse an opioid overdose when you've already given a large amount of Narcan and you're missing the fact that the patient is hypoglycemic or the patient was, had a assault and head trauma. And, unfortunately, some of our addicts are not always hanging around um, people who follow the law very well, and so assaults are very common on patients. And so just be aware that, hey, I just gave 4 milligrams of Narcan, and this person who always wakes up with Narcan did not wake up or have any change, or I've given 8 milligrams and had no change. It might not be an opioid overdose. And so just keep that in mind. These patients are high risk for a lot of different things, and we just don't want to be anchoring and missing something else that we can be treating. I always try to do a drug highlight in every lecture I do, so we'll go ahead and do fentanyl. I apologize, I don't know what you guys are carrying on your trucks for opiates, if it's fentanyl or morphine, but obviously you're going to encounter fentanyl, not even in just the therapeutic sense, but also just on the streets. So fentanyl is a synthetic opioid that binds mu receptors. And so the dosing, so the typical dose for an adult, you can give 1 microgram per kilogram and then follow that with a half dose up to every 5 minutes. So I believe the state of Pennsylvania protocol is 300 micrograms, the last I looked, as the max dose that the patient can receive. It's a great medication for fast symptomatic relief. It is a little shorter acting than some of the other opiates we use, but it is one that I particularly use in trauma pretty frequently. Um, It does have a life of approximately 2 to 4 hours. Just beware that if you give it intramuscular, it lasts a little longer. And then it's mainly excreted through the urine. So, that's always helpful knowing how drugs excrete it, because if someone develops renal failure or liver failure, you kind of know that those patients are going to react to the medication a little differently. I really like this chart because it shows the kind of duration of action and half-life of the common opiates that we use and just the common opiates that we see abused. And if you look at all of them, the half-life of all of these drugs is between 2 to 3 hours, and the duration of action is 3 to 6, 3 to 12, 24 hours for methadone, 48 hours for transdermal fentanyl. And why this is so important to remember this chart is Narcan has a half-life of about 60 to 90 minutes. And so if you look at this chart, the majority, if not all, of the opioids that we're seeing on a regular basis have a longer half-life than the Narcan that we're administering to patients to reverse them. And that is why we always talk about how important it is to tell patients that we really want them to go to the hospital after they get Narcan. You can have rebound of symptoms even if you don't reuse again. These symptoms can come back just as severe. You can stop breathing. This medication, Narcan, doesn't last as long, and I really, really do think it's important to explain that to patients, just because it's a very high risk refusal. Now I understand, obviously, when someone has capacity to make a decision, they're going to obviously, honor the patient's autonomy and decision making, but you really want to make sure that they have the right information to know this could kill me because the medication that you use to reverse this opioid is not going to last as long. And this chart here is just the proof of that. Why, from the scientific end, does that case happen? All right, next is uremia. So this is where we think of our dialysis patients. Is this a dialysis patient that missed their treatment? Is it a dialysis patient whose last treatment got cut short? Was there changes made to how their dialysis treatments have been occurring? Unfortunately, there's a lot of reasons why patients miss dialysis. Could they be sick and they've missed it? Is it just non-compliance? Have they had transportation issues? But it's pretty common, and these patients come in, and it could be simply that they're just sleepy and lethargic, or are they having seizures or in a comatose state? Uremia over time, unfortunately, is kind of permanent in the sense that they can have permanent changes to their basal ganglia on their brain, and that leads these patients to sometimes have some kind of altered states or confusion. But acute uremia in and of itself can cause acute changes in mental status. The next is T for the tips part to start there, and that would be trauma and temperature. So think about head trauma, obviously. Think about hemorrhagic shock leading to altered mental status, and then hypo and hyperthermia. So head trauma, bleeds, concussion, all these, of course, can cause unresponsiveness, seizures, abnormal behavior. If you can get from the history that the patient had some head injury, that's definitely helpful to figuring out what could be causing it. Shock in general can just cause altered mental status. So in trauma, if you develop hemorrhagic shock, sometimes you notice these patients will come in, or you'll have them in the ambulance, or we see them in the trauma bay, and they are, just kind of not acting normal. They're slightly responsive, and if your blood pressure's pretty low, it's going to be hard to perfuse your brain effectively to maintain your mental status. And then hypo and hyperthermia. So, obviously high temperatures or low temperatures can cause this, but also do you see this in endurance athletes, or just like a local marathon or 5K and it's a high temperature, or people out and about at a local festival in the heat, or is it an elderly person that's been in their home that doesn't have air conditioning in the summer or heat in the winter, and they're not getting around to getting it fixed, or they don't have access, or they don't have the financial means? And so, these are unfortunately pretty common, and can make a patient be pretty confused. This here is just, like I said earlier, how you can get those permanent changes for muremia. So I always find it interesting to kind of put a visual with some of the things that we're saying. So as you build up uremic toxins, these patients over time can build up permanent changes to their brain. This here, you see that kind of enhancement right along the middle there. They call it the lentiform fork sign. And unfortunately, these patients can have permanent brain damage from this. Some interesting EKGs on the hypothermia end. You'll see Osborn waves or J waves. So if you look there, you'll see that kind of J wave at the end of the QRS. And this is another example of that, just a little more extreme. So next is the next I, which is infection. So sepsis, UTIs, meningitis. Sometimes patients who have been sick for a while obviously can develop septic shock. They can develop metabolic acidosis. It could be from really anything: pneumonia, wounds, cellulitis, and UTIs. Obviously UTIs are a common cause of altered mental status in the elderly, or those that might not be able to care for themselves well. Meningitis, obviously infection of the meninges, both viral, fungal, and bacterial, all can cause, unfortunately, effects on the brain that can lead to, unresponsive, to just confusion, to abnormal behavior, headaches, other infectious causes of altered mental status. Viruses can cause people to become pretty sick, as we've probably unfortunately all encountered over the past couple of years with COVID, flu. If you just develop severe symptoms from any infection, it can lead to altered mental status. P, so think of poisons and psychogenics. So tox is probably a whole talk in and of itself of causes of altered mental status, but just things to think about: carbon monoxide, cyanide, organophosphates, just patients' home medications, pesticides, solvent exposures in the workplace. Like I said, cyanide and carbon monoxide in your patients from house fires. Someone that has a generator running close to the house, and they develop carbon monoxide poisoning. These are all pretty, unfortunately, can be pretty common exposures. Psychogenics, hopefully we're not seeing as much of these, but unfortunately they are pretty common. I know where I did residency, PCP was pretty popular. We saw it pretty frequently, but there's other, maybe less commonly used, but like mushrooms, ecstasy, other synthetic drugs. I know we probably all unfortunately encountered some of those synthetic marijuanas that were going around that were causing just extreme agitation, strength. And then just, some of your more common drugs that you see: meth, cocaine, LSD. You can definitely, unfortunately, get pretty altered with those. People's judgment can be altered. They can do risky things. It can change vital signs pretty dramatically. So all of these can be causes. So if you notice that has history of use or is, admits to it, that could definitely be the cause of their altered state. Nice little chart here with just common toxidromes. So, something to look over if you have the time. But knowing your toxidromes sometimes can help you figure out causes of what the patient may have overdosed on or been exposed to. I always, like I said, love throwing in EKGs. So you can have tricyclic overdoses. So they can be commonly prescribed for psychiatric patients, and people unfortunately will take these in suicide attempts frequently. And so you'll see here that you start to see a QRS widening, and these can lead to pretty dangerous arrhythmias. So wide QRS, long QT, large terminal R wave at these EKGs. So if you had someone and you noticed that they had an empty bottle of a tricyclic and they're altered, and you see this EKG, it's definitely something to be concerned about. You'd want to keep them on the monitor again, and they're very prone to arrhythmias. And then the last one here to go over is S, so strokes and seizures. So obviously, like we talked about in our assessment, looking for focal deficits is important. And it's hard. I will say I find it hard even times with sometimes parsing out is this a stroke or not. Unfortunately, it can be really difficult to pick up on the completely unresponsive patient. But what you should see some kind of hard neurologic deficits. So obviously strength loss, sensation loss, or do they have coordination loss with walking or moving, finger to nose? Do you notice gaze deviation? These are all things that you might see, or is it just subtle? Are they having trouble every now and then expressing their words or slight slurring of their speech? But strokes are definitely concerning causes and obviously very time pertinent. Then epilepsy, other causes of seizure, like I said earlier, trauma, bleeds, and tumors can all cause seizures. And these patients, can have a postictal state where they're aggressive, confused, and that's really a hallmark of a true seizure is that they tend to be postictal. So making sure that you're trying to treat them accordingly, and obviously following your protocols for that with benzodiazepines, and then keeping that patient kind of monitoring their airway, and then getting them to the closest ER is important. Um, and then overall, I just kind of added this into AIU tips is to remember that altered mental status can often be multifactorial. So, there is no simple explanation for every altered mental status patient. Yeah, sometimes it's as simple as a low blood sugar or they're septic. But a lot of times it can be multiple things. Could it be that they overdosed and they had a traumatic injury in the midst of their overdose? They fell down a flight of stairs when they were intoxicated. Um, is this sepsis plus renal failure? So, they became septic and they take chronic morphine and now they're not clearing it as well. And so, because they're developing renal failure from their sepsis, or and now it's leading to building up of that opiate, or is it that they're becoming uremic because now they're in acute renal failure from their action? Nothing is unfortunately simple, and single causes are not always the reason for why our patients confuse. So, just keep that in mind when you approach these patients. If you see something that you think could be kind of multifaceted, it's important to pass that information along. And so, why is gathering this information and doing this assessment pre-hospital so important? Is you're really gathering all the information sometimes that we have to figuring out what's going on. Obviously, it's really important to you in making your decisions on how you need to treat that patient, what interventions you might need to make immediately. But even after that, you're really trying to put this puzzle together so that when you pass on that patient to someone else for care, you're giving information that's helpful to them. You are really truly the eyes and ears for the ER physician when you're out of the hospital on scene there with these altered mental status patients, because I'm not out there. I don't see what's going on. I can't gather any of that information. If the patient's completely unresponsive and they come in, we don't have a lot to go off of at times if the patient can't tell us, just like you can't. And so if you are able to gather information from the scene, or you've kind of do in your mind kind of that differential of different causes, and you've kind of hit a few that you're like, it definitely, there's signs of these. That information when you do your patient handoff is huge, and sometimes really the only, like I said, only information we're getting to try and solve this or treat the patient. So your scene observations, your patient observations, discussions with those around the patient, gathering meds and information might be our only chance in figuring out the cause for the patient's mental status in a timely manner. So I am, very appreciative to all you guys and the amazing providers out there that while you're on scene trying to acutely treat this patient, somehow are multitasking into getting the effective information we need to treat these patients going forward. So overall, I know that lecture is a bit all over the place. I guess that kind of goes along with altered mental status. But really the reason is altered mental status is not simple, and there are so many causes. But I think that thinking about them and thinking about the reasons that that the patient could have the altered state can help us, like I said, in the acute phase treatment, but also down the line and getting that patient an effective care plan. And that plan, like I said earlier, carries on. It's not just, while they're in your hands, it's not just while they're in my hands in the ER, it's while they move on to their inpatient stay. That information often can carry their complete course of treatment. And we want to make sure that we're all giving our patients the best we can. And like I said, this is such a hard area to manage. I know that sometimes it's one of my least favorite chief complaints to see because it can be so challenging, but also at the same time, it can be so rewarding when you sit and you can figure out, such a difficult patient case, kind of like a detective, and figure it out. And so I think that's partially what draws all of us to this. So I really appreciate everybody kind of listening to me. And like I said, I apologize. I know altered mental status is kind of a little bit of an all over topic, but overall, I think it's a really important thing to continue to review and know, kind of going forward in all of our care for our patients. So I wanted to give you my contact information. Like I said, I apologize that I can't do this live, but if you have any questions, if you see me in the ER, feel free to stop me and ask. You can shoot me an email and I will get back to you. I'm always happy to talk to anyone. If like I said, if you encounter me in the ER at patients and you have a patient, if you ever, feel like you need to just tell me something about them, you're worried about something, you see me at the desk after you hand it off the patient, come on over. I'm always happy to talk. So I really appreciate working with everybody. I've really enjoyed my time so far working at Lidditz and working with all you guys, bringing patients in here to us. And I look forward to working with you guys again. So thank you for letting me give this talk. And I hope to be able to spend some time with you guys again in the future. So thanks.